Ritchie, I'm glad you're here. And to have taken the time to hear Dr. Ritchie speak on palliative care. It gives me pleasure to introduce her. Her credentials are most impressive, both academically in terms of education, teaching, research, but also in writing so many articles about her findings and in direct clinical care with patients. As a graduate of Davidson College and the University of North Carolina at Chapel Hill School of Medicine, she completed her internal medicine residency, chief residency, and geriatric fellowship and palliative care. Wait, I skipped a line there. At the University of Alabama in Birmingham. She is both a board-certified geriatrician and palliative care physician and has long-standing experience in clinical care delivery methods, models, medical home care, and advanced illness research. Her current goal is in building a research program at UCSF at the interface of palliative care and geriatrics that seeks to improve the quality of life and patient outcomes for those experiencing complex, serious illnesses at any stage of life. I must mention before having Dr. Ritchie begin that we're on a timetable here today, and we'd like you to be thinking of questions, and there will be some time for questions before we end almost promptly at 3 o'clock. Thank you. Thank you very much.
Good afternoon. Can those of you in the very back hear me?
Yeah.
Very good. Okay. Well, it is a terrific honor to be here with you. This is definitely going to be the best part of my day, to be able to spend time with you, to both be with people who I always feel a sense of affinity with, and also to talk with you about a topic that often is sort of considered, quote unquote, a dirty word, but I think is very important for all of our well-being and our opportunity to live our best lives in the way that we think most represents them and most represents what's important to us. So what I want to do today is I first want to talk to you about what palliative care is. What is that word, which is very hard to say. The origins of palliative care, so where did this word come from and what was sort of its start. And then talk about what we know from the scientific literature about its impact and why it's worth thinking about and pursuing and asking for it. And then talk about some very common obstacles that we have faced, particularly here in the United States, with respect to palliative care, and some ways that you and I can overcome them. So that's what I'd like to do over the next less than an hour together. So I want to start by asking you what you think palliative care is, because I find that many people have a wide array of perspectives about what palliative care is. So I'm going to be Vanna White, and I'm going to come around, and I'm going to ask you, but you can volunteer. So who would like to tell me what they think palliative care is?
Symptom management.
Symptom management. Somebody else?
Pain relief.
Pain relief.
Comfort management.
I'm sorry, I missed that.
Comfort management.
Comfort management. Okay, we've got a lot of good words around comfort. Anything else?
Alternatives to some medical procedures.
An alternative to some medical procedures? Anyone else? Okay. Well, everything that you have said is true, and it's part of the truth, so I look forward to telling you about some of the other things that palliative care is, so that you can have a holistic perspective about it as you move forward into your own life and the lives of those that you love. So, if you aren't completely clear about what palliative care is or is not, you're not alone, because many people in the United States actually do not know what palliative care is. So if you ask them, how many people are familiar with the word hospice, you'll see that by and large, most people have some idea about what hospice is. If you ask people what end-of-life care is, maybe not quite as many know what exactly that means, but still quite a few. If you ask people what palliative care is, more often than not, I would say only a quarter of the time are people familiar with that term. So you are not alone, and oftentimes when I'm on planes, just for fun, I will talk to the neighbor next to me if they're willing to talk and they don't have their big Bose speakers on, and I'll say, so what do you know about palliative care? Just to see what they say. And their perspectives are wide and varied. What I want to do is I want to give you a definition that was put forward by one of our sort of national organizations called the Center to Advance Palliative Care, for a definition of palliative care that I hope you will stick with you and that you will also communicate to others for what palliative care is. So palliative care is specialized care. You heard from Sarah that I have board certification in palliative care, so it is a specialty of internal medicine and actually other specialties that's focused on the care of people with serious illness. And as you all rightly stated, it's about symptom management, it's about addressing issues related to pain, distress, and it's also about quality of life, and I think some of you use the word comfort care, so it includes that. It has to be provided in its best version by a team of people from multiple different disciplines that help provide a truly holistic and interprofessional perspective, because most of us who go through training, whether or not we go through training in social work or nursing or medicine or chaplaincy, are not all taught the same thing. So there's value in having that sort of interprofessional perspective. And here's the big thing that people don't know about palliative care, and that's the last red line. It is appropriate at any age and at any stage, regardless of whether or not it is a diagnosis for serious illness or near the end of a journey with a serious illness, and whether or not someone is choosing curative or what we call disease-modifying therapies. And that's very important for people to understand, because oftentimes what you'll hear from even my colleagues in medicine is if you were to say, you know what, I have a serious illness and I would like to have palliative care involved, and they will say, you don't need that yet. You're not ready for that yet. Well, actually, the truth is, if you're experiencing any kind of distress as a result of your serious illness, or someone near you who loves you is, you are ready for palliative care, because it is not predicated on your prognosis, and it is not predicated on whether or not you're getting curative therapies. So if there's anything you take home from today, I hope it's that palliative care is appropriate at any stage of a condition, and is also appropriate while someone is also getting disease-modifying, or what we often call curative therapies. And that is where I think there's often a misunderstanding about what palliative care is, and that's what I hope to set straight here. So, just to reiterate what I just said, palliative care is not end-of-life care. End-of-life care can be a part of palliative care, but palliative care is much bigger than end-of-life care, because it's really about supporting somebody who's experiencing the challenges of any serious illness across that illness duration and continuum. It was not uncommon for me when I was part of a big outpatient palliative care practice for us to see many people who were survivors of a number of different conditions, so both neurologic conditions or respiratory conditions or cancers, who still had high illness burden and high levels of distress associated with their conditions. They benefited greatly from palliative care. They were not at the end of life. Certainly, it's appropriate for people to receive palliative care at the end of life, but I just don't want you to think that palliative care equals end of life care. All right, I think I made my point. It is really care focused on improving quality of life regardless of where people are on their illness journey. Okay, now, one of the things that we used to talk about when we talked about people, and this is how I grew up in medical school and when I did my training, is that when someone was given a diagnosis for a serious illness, they would go along the way, they would get what kind of whatever treatment we could come up with, and then when there was quote unquote nothing more we could do, we would do what we would call throw them over the brick wall from that whole array of treatment to hospice care. That was very distressing for many patients and their loved ones. They suddenly lost touch with all of the people who'd been providing care for them up to that point. It was just this sort of like all or nothing sort of phenomenon. And really we realized that that's not the way illnesses actually are experienced by people. You know, if I get a diagnosis of a serious illness, I'm feeling distressed at that moment, regardless of what's happening to me 5, 10 years from now, or 6 months from now. And at that point, I can benefit from the holistic kind of support that a palliative care community or practice can provide. So now we think about it more this way, and I apologize that the letters of palliative care are in red. It's very difficult for me to see that, so I'm guessing for those of you in the back it also may be difficult. If you're in the back, the blue part is palliative care, the green part is what we call curative care, disease-modifying care, and then red is where most people get hospice. The point about this is that across the whole duration of someone who is experiencing a serious illness, they're going to have ebbs and flows of when they need and benefit from the kind of services that palliative care focus on, which is about quality of life. There will be times when they're doing fine. They probably don't need any additional support. Life is going great. And then they have a little exacerbation of some kind or some kind of untoward event. And then things get complicated and difficult and distressing. And then for a bit, they may benefit from some palliative care. So there are these ebbs and flows that you see here. And particularly for, at least historically, for non-cancer conditions, this was the case. So if someone has advanced heart conditions of any kind, especially what are often called heart failure, they often will do okay, and then they have a bad spell where their heart failure sort of becomes uncontrolled. And that's often when they're experiencing the largest amount of distress. And then they do better for a good bit of time, and then they have another one of those, what are called sort of exacerbations. And it's often during those exacerbations when their symptoms are out of control and things are not going well where they benefit from palliative care services. I'll talk about hospice in a minute, but I want to just again reiterate the appropriateness of palliative care across the disease continuum. And what we often say is that the goal of palliative care is to help people live as well as they can for as long as they can. And what as well as they can looks like for each person is predicated on their own values and what's important to them. But what that well as they can looks like. All right. I've also stated this, but just again to restate the obvious, is that palliative care is not only for people who are older, it's for people who are children, for people who are early in their life course, wherever they are when they experience a serious illness. And it also is appropriate in every setting. Now in the United States we have some impediments to receiving palliative care in certain settings, which I will get to if we have time, but it is reasonable and appropriate for people to experience and have the opportunity to access palliative care in any setting. Now, how does palliative care differ from hospice? So, all hospice is palliative care, but not all palliative care is hospice. If you think about palliative care being an umbrella that focuses on quality of life, hospice focuses on quality of life when someone is actually at the final stages of their life and where nobody would be surprised if in weeks to months that person came to the end of their life. So hospice is predicated on prognosis in the United States. By the way, that's not true in other countries, but in the United States, because in 1982, when Medicare, the Center for Medicare and Medicaid Services, instituted hospice as a benefit, they basically said, you can only get this if your doctors say that you have 6 months or longer, or 6 months or less to live. Now, most of us who are doctors know that we actually aren't, crystal ball gazers, and we can't actually look into the future and tell exactly when someone's going to be at the complete final days of their life. But we have some indicators or some clues, and so we are much more loose about that. And in fact, most of us will say, if we weren't surprised if someone came to the end of their life in the next 6 months, we think they could potentially benefit from hospice. But if they live 5 more years, then we all give a shout of joy. Or if they live, 3 more years or 6 more months or 1 more month, because we, truth be told, we don't know truly about what someone's actual prognosis is. All right, so why, and then, the other thing I want to mention about hospice is that many people only think about hospice as its orientation towards someone who has a limited prognosis. And that's hard, that's difficult for most of us to even accept for ourselves or for our loved ones, that perhaps someone's life is truly coming to an end and they're really in the last chapter of their life. That often is then what's forgotten. There's some of the real benefits of hospice care, and one of the biggest, in my estimation, as a healthcare provider and as a person whose loved ones, many of them, have received hospice services, is this 24/7 access to palliative care experts. That is, that regardless of what time of day or night it is, if you're receiving or your loved one is receiving hospice care, you can call on the phone, and if possible, and they're available, a nurse or a nurse-related provider will come and see you at that moment. There's almost no other care in the United States that's equivalent to that, where you have that kind of sort of 24/7 access to care, and that's very important and special. Many people, when they experience the benefits of hospice care, that holistic of support, that interprofessional level of care, and especially if it's a high-quality hospice, will say, I really wish I'd gotten this way sooner. Because unfortunately in the United States, even though you have to have a prognosis of 6 months or less to receive hospice, what do you think is the average length of stay for most Americans who die receiving hospice care? 3 weeks. Good job, whoever said 3 weeks. It's 21 days. And actually that number hasn't changed much. The variation has increased. What we do know is that people, for example, who go on to hospice who have dementia as their primary diagnosis, we're particularly bad at prognosticating for people who have dementia. They often will have a longer length of stay. Some of them may even, quote unquote, graduate from hospice. But by and large, most people will only be on hospice for like a week, 7 days, and that average of 21 days is taking into account the wide variation. All right, so why is palliative care become so important? This is something for us to celebrate, and that is, may sound weird, but it is only because we actually are living long enough to be able to benefit from these kind of services. So back in the day, most people in the 1900s, they didn't live as old as I am, let alone older. And so now, the average life expectancy, you all may have seen this, just came out in the news last week, is actually leveled in the United States and is declined a little bit. But still, we're talking about high 70s, high 80s. That's the average, and that's from birth. If you actually make it into your 80s, your likelihood to live well for the next 5 to 10 years is even much higher than that if you've actually made it into your 80s. So we have this luxury of living a much, much longer life. But the cost of that longer life is that we often are living with serious illness. So back in the day, when we had a heart attack, we died. Now, we don't die, which is terrific. But we often will live with a heart muscle that's weaker. And we may be walking around with a heart muscle that's weaker for a long period of time. Back in the day, when someone had a respiratory arrest, they didn't make it through that respiratory arrest. Now many people do, and that means they get to live for a longer period of time with those illnesses. Back in the day, when you were diagnosed with metastatic lung cancer, that is lung cancer that's gone, for example, to your liver, we didn't anticipate people living more than 3 to 6 months. There are now, with immunotherapies, people who live for years and years. So this is good news, but it also means we are not living cured. We are living with serious illness. And if you're living with serious illness, then you're often living with the symptoms associated with that serious illness, or with the symptoms associated with the treatment for that serious illness. So that changes the dynamic for all of us when we're walking through that. And it means that we have to think more about how do we support people when they're living longer with some kind of serious condition. In the 1900s, most of the care that was provided in the United States was by family members. Now, actually, the predominance of care is cared by others. Most of the medical care costs were low because we didn't have much to offer people. Now we can offer a lot to people, but it's very costly. And unfortunately, some of that high-cost therapy is not effective. So what we're doing is we're providing high-cost care in a way that actually can cause distress and harm because we're not very good at figuring out who really can benefit from it and who actually can't. And what we know in the United States, based on a lot of research, is that here in the U.S. in particular, we make serious illness harder than it has to be because our default approach towards any kind of serious illness is to throw as much technology at someone as we possibly can, even if that technology may not benefit them. So here in the United States, we find that people are experiencing high prevalence of pain and other symptoms compared to other countries, high risk of functional dependency, lots of issues around cognition, and this is the most difficult piece, not the accompanying social, psychosocial, or spiritual support to help them along the way. And what we see is that people in the United States receive care that they don't want or from which they cannot benefit, and they fail to receive the care that they do want and from which they will benefit. And this disconnect is really what led to the palliative care movement. Back in the 80s, a woman by the name of Joanne Lynn put together a very large study in some of the best hospitals in the country and said, how can we make sure that we are actually providing the care that a person says that they want? And when we looked, we found that people weren't receiving that care, so we said, she said, we're going to do this big clinical trial, we're going to intervene, and we're going to make sure that people get the care they want. They still didn't get the care they wanted, and she found that people were dying in pain, with shortness of breath, with high levels of distress, and also high levels of distress for their caregivers. And in my estimation, that's actually when the palliative care movement was born in the United States. There was this huge recognition that even though we have all this great technology, we're still not addressing the way people die in a way that promotes their dignity, their well-being, their quality of life, and the quality of life of those around them. So this is essentially what we ask of people in the United States in our healthcare system. And for those of you who can't see it in the back, this is in a doctor's waiting room, and it says, "Thank you for suffering in silence." And that's essentially what we ask of people. And we still do, unfortunately, because our system is still not put together in a way that's really patient and family-centered yet. So when you ask people, and these questions have been asked here in the United States, they've been asked in Canada, Europe, and many other countries in the world, what they really want when they're seriously ill, this is what they'll say. And you all brought this up. You said, comfort, relief of pain, relief of other symptoms. People want relief of symptoms. They actually also want to know what is going on. They want to have good communication about their illness. They don't want to be pussyfooted around for the most part. They actually want to know what's up. And they want help with making important decisions that are aligned with their values. What that means for us as healthcare providers is we actually have to ask people what their values are and what they care about. But that's what people say they want. And they also say they want support, emotional, psychological, and spiritual support. So Dame Cicely Saunders, who is actually, she was at first a nurse, and then she became a doctor in the United Kingdom, and was the founder of the first hospice in the United Kingdom. said, pain demands the same analysis and consideration as an illness itself. It is the syndromes of pain rather than the syndromes of disease with which we are concerned and with which most people are concerned. When you ask people what they're afraid of, what they're in their life, they don't generally say, I'm afraid of dying. They say, I'm afraid of dying in pain. I'm afraid of dying not in control. I'm afraid of dying in a place where I don't want to be or where my family or other loved ones are not with me. And that was the part that we as a healthcare community we were not focused on. We were focused on the disease and trying to deal with the disease. And it was only when people like Dame Cicely Saunders and Joanne Lynn and others, sort of Balfour, who is a surgeon in Canada, sort of highlighted the fact that there was a disconnect around what people were saying they wanted and what they were receiving, that really palliative care came into existence. And in fact, Balfour, who is a surgeon in Canada, was the one who coined the term palliative care. So we can blame him if you have trouble understanding what the word is or even pronouncing it. It takes a while to even get the word to flow out of one's mouth. But he basically saw that palliative care was around relief of suffering, alleviating, sort of palliating, putting a cloak of care around someone, and that's why he coined the term. Now, that all sounds nice. The question for many of us is, well, what actually happens if you get palliative care? And am I like, quote unquote, giving up if I get palliative care? That's what a lot of people think. So here's what we know from a number of studies, but I want to highlight one that came out about 8 years ago, which was a study. I remember I mentioned lung cancer patients. This was a study of people with advanced lung cancer at Massachusetts General Hospital, which is one of the Harvard hospitals in Boston. And what they conducted is they conducted a randomized clinical trial, which is one of the most rigorous kind of clinical studies that you can do. And what they basically allocated people to was either you receive palliative care services the minute you're diagnosed with stage 3C or 4 lung cancer, or you get it whenever your doctor decides you need it, okay? So you either get it right at the point you're diagnosed, so what we call early palliative care, or you get it afterwards. And they randomized 151 people. All of these people presumably got good cancer care. We hope that they got good cancer care if they're at Mass General, and then half of these people received simultaneous early palliative care. And what we found is, hopefully you would not be surprised by this, that these individuals had better quality of life, less pain, shortness of breath, nausea, less depression, lower chance of dying in the ICU, and here's the thing that was probably the most surprising to all of us, they had improved survival. So up until now, people sort of had this sort of back of the mind thinking, secret worry that if I choose to receive palliative care, especially early in my diagnosis, maybe I'm giving up. Maybe I won't live as long. And most of us, we want to live as long as we can. And what this study showed, and now several other studies have shown of palliative care, is that when you receive palliative care services, especially when you receive them early, you're not only going to have improved quality of life, but you're likely to also live longer. Now, if you think about that, maybe that's not surprising to you, because if you're not in as much pain, if you're experiencing less distress, if you feel more connected to your family and your loved ones through that kind of holistic support, maybe you feel more like living. Maybe you're less likely to give up. But this was a very important finding because it helps allay some of those, I think, back of the mind fears that people have around palliative care. Another study that was done that looked at a palliative care intervention that was done by telephone. It goes through sort of 6 sort of key modules of issues that are important to people when they have a serious illness. And this project was developed by a woman by the name of Marie Bacchitis, who is actually at Dartmouth, and now she's at the University of Alabama in Birmingham. And they looked at cancer patients in a rural setting. So it's very hard for these people to actually come into a clinic. And they provided these palliative care services by phone. And again, what did they find? Improved quality of life, decreased depression, and an increase in survival. pretty shocking. That was not expected. But more and more for these palliative care interventions, we're looking at survival because we all want it. Most of us, not everybody, but most people do want to live as long as they can. And I think it's important to keep in mind that when you're receiving palliative care, you're not giving up on living longer. You're embracing the opportunity of living longer better. And that's really why it becomes important. So if it's so good, why is it so hard to get? So I want to talk to you about some of the common obstacles to receipt of palliative care. The first is they don't want to take away my hope. So we often will see this not from the person who is actually in need of palliative care services, that person who has a serious illness, but their loved ones. Their loved ones will say, I don't want you to talk about palliative care because that might mean somebody's hope will be taken away. And to this I would say, well, what are we hoping for? Because this gets back to people's values, right? So if the only hope is for living as long as possible, then perhaps that hope is modified. But if the hope is for living as long as possible, as well as possible, that's what you're offering. You're offering a hope to live as well as possible for as long as possible. And what we often realize about hope is that there are many things we can hope for. And most of us, we hope for experiencing love in our life. We hope for a sense of connection. We hope for the opportunity to give and receive forgiveness. We hope for all those sort of things that are also part of hope. And those are things that are never taken away from us. We have those opportunities to be hopeful for those things, regardless of where we are on our illness journey. There's always a place for hope, even when there's no cure, for comfort in the face of suffering, and for all that can be still, despite all that cannot be. And I think for those of us, and especially those of us as we age, we all experience that in some way or other. We're all experiencing loss, and we're all experiencing gain from what we benefit from the growth we experience in the loss, if we so choose to embrace that growth. So that is really, I think, an important thing to talk to people about when you hear someone say, I don't want to tell them about palliative care because it would take away their hope. First and foremost, most people who have a serious illness, they know they have a serious illness. And most of those individuals deeply appreciate being able to have frank conversations about what their fears are, what they're worried about, with people for whom it's part of what they do, and they don't mind it. Amy Berman is a colleague of mine who is in New York City. She works for the Johnny Harper Foundation, and she has been diagnosed with stage 4 breast cancer for about 5 years. And she has been always the first one to pull up a clarion call for palliative care, basically saying that she thinks the reason she's living as long as she has is because she has embraced palliative care from the minute she got that diagnosis of breast cancer. Which when she got it, it was as not quite as advanced as it is now. I think the thing with hope is that hope can be enduring. And hopelessness, if someone is truly hopeless, that suggests that they may have actually a physiological phenomenon going on, like depression, which then we should investigate, and we should think about how we might be able to treat it. And depression, even in the context of serious illness, is not normal. So a lot of times you'll hear people say, well, it's no wonder they're depressed because they had A, B, C, D, and E happen. Most of us as human beings, as Homo sapiens, we're pretty resilient. And even in the face of tremendous adversity, we will be able to experience hopefulness for something. And so when someone is experiencing hopelessness, that's often a clue that they might benefit from a holistic approach towards addressing their fears, their concerns, their depression, etc. The next obstacle you hear is it's too soon. Remember I told you earlier on that it's not uncommon for me to hear my colleagues in medicine say, palliative care is great, but they don't need that yet. And I was like, yet meaning yet what? Yet when essentially they're not able to enjoy life anymore because they're really truly at the end of their life. I want people to experience palliative care early on so they can live their best life when they're sick. And that doesn't mean waiting till the end. So that is often what you'll hear. And you may, as a loved one or someone who's experiencing serious illness yourself, have to push against your healthcare providers about this particular issue. It's not been uncommon for me at all to have friends from around the country call me and say, I can't get my doctor to send me to a palliative care doctor. And I was like, okay, well, you know what? This is an opportunity for you to have a good, frank conversation with your doctor and maybe educate them about what palliative care actually can do for people and what it can do for you. And then the other thing to keep in mind is that people often do want to know if there is something serious going on. I promise you, if I have weeks to months left, I want to know that because I have a lot of things I want to plan to do. And I have some conversations I want to make sure I have. There's some things I want to do. If I have the luxury, especially, of knowing that when I'm compass mentis, that is, if my thinking is well enough that I can actually have those conversations. So it's important to keep in mind that all of us live our lives differently if we know we have a short period of time to live. That is the gift I get to experience every day as a palliative care provider, because I get to vicariously live in a place of uncertainty through the lives of my patients and understand the gift, the absolute preciousness of each day. And I would say that that's the gift I get. So, people say, well, it must be depressing for you to be in palliative care. Actually, no. It helps me savor each minute. It makes me remember I have to text my son and tell him how much I love him. I have to make sure I'm communicating gratitude to those people for whom I'm grateful in my life. And if I didn't have that sense of urgency, which is what I think serious illness can do for us, then I might miss out on the richness that life can offer. So in a weird way, serious illness can be a gift because it enables us to savor life in a way that's much more aggressive than we might otherwise. Finally, this whole idea about it being too soon means that when we don't talk to people about what's actually happening in their lives, we miss out on important conversations they can have with us or we can have with them. We miss out on opportunities for preparation. We miss out on opportunities for people to hear our story and to bring closure to important relationships. So I've had a lot of death in my family recently, and one of my sister-in-laws is now living with advanced cancer. She gets this completely. She's thinking about her granddaughter. She's thinking about the videos she wants to make for her. She's thinking about making holiday cookies, which they're doing right now. This has sort of given her increased clarity. And she's deeply grateful for the fact that she actually has been able to prepare. Because another colleague of mine, her dad died in a biking accident. He didn't have that luxury. That is the one luxury we have when we have a serious illness that gives us time to prepare. So I think that's something also to keep in mind. And when we do bring closure to these relationships, it gives us the opportunity to say those things like, forgive me, I forgive you, I love you, thank you, goodbye. And those things are left as memories for that person for the rest of their life. It is a gift that we give others when we do those things. And then the other big obstacle is this idea, it won't happen to me. It's going to happen to other people, not to me. And then what that means for us is our loved ones will have the challenge of not knowing what we want. They will experience confusion, trauma, stress, regret, because they didn't know what was important to us. And that's why if any of you don't have an advance directive that you have discussed with your loved ones so that they really understand what is important to you, what you value, I strongly urge you to do that. This is a gift you give other people when you tell them what's important to you and what you would and would not want if you were to become so seriously ill you weren't able to make those decisions for yourself. This is a study that was done also with people with cancer. There are studies done with people who don't have cancer, but the ones I'm showing you are. And what they did is they asked people if they had discussed with their doctor particular wishes about the care they would want to receive if they were dying. And about a third of the folks had a conversation, and 2/3 hadn't, which, by the way, is not terribly surprising. I can tell you that in my august institution, about a third of the folks who would benefit from having an advance directive actually have one in their electronic medical record. So there are a lot of folks for whom this conversation has not occurred. But what they found is that those people who had the conversation actually were less depressed, less terrified, less worried, and it did not cause them more distress. It actually caused less distress because they were actually planning ahead. So keep in mind that planning ahead for what those things are that you want or don't want to have happen when you're seriously ill, and most importantly, communicating that with those people in your life that need to know that is one of the biggest gifts that you can give to other people. What it means is those individuals who do that have a higher likelihood of having a better quality of life at the end of life. They're less likely to die in the intensive care unit, and they're more likely to have better outcomes for loved ones. How many of you have had a loved one die in the intensive care unit? Okay, a couple. Surprisingly, not that many. For many people who've had a loved one die in the intensive care unit, it was not an easy experience. It was a very difficult experience. Many people experience a lot of trauma associated with having their loved one die in the ICU. That is the default form of care that we provide people in the United States, unless we are told otherwise. And so it is important to have these conversations about what kind of treatment you would or would not want to have if you were seriously ill. So here's some questions that you can think about having with those people in your life who are important to you. These are questions that come out of what's called the Serious Illness Project that was developed by a person that you all may know called Atul Gawande. Have any of you heard of Atul Gawande? He wrote the book Being Mortal, and if you haven't read it, it's a great book. But he basically came up with some very simple questions that I love to ask because they don't feel so kind of threatening, that says, when you think about what lies ahead, what worries you most, and when you think about the future, what do you hope for the most? If you're even able to have those conversations with the people in your life who matter to you, they're more likely to understand what's important. And the more you can communicate to other people what's important to you, the more control you will have through them and through your healthcare providers about what happens to you in that final chapter of life. So to sum up, palliative care is for anyone with a serious illness, not just those who are at the end of life. Our goal in palliative care, and I'm guessing it's not too different than most of the goals that we have together in this room, is to have the best quality of life for as long as possible. What we've discovered, in a kind of way surprising, that palliative care does help people live not only better, but longer, which honestly was a bit of a surprise. And that conversations about end of life don't have to be scary. They don't have to be, in hushed tones. They can be a really joyful part of our life together. And they actually are the most joyful when they're done in a way that makes it normal to talk about, where we're actually able to sort of speak honestly about what we are afraid of or what we're hoping for, and when we're able to communicate that not in the crisis of the moment. So if you haven't had that opportunity to have those important conversations, I would really encourage you to do that. And you know, if you have, my hope for you is that you actually have helped those people in your life who care for you know how to care for you better should that moment ever come when you're seriously ill and folks are not able to, and you're not able to speak for yourself. So with that, I'm going to stop. I wanted to make sure that we had some time for questions. So thank you for your attention, and I look forward to your questions. Yes?
You didn't describe what the actual components, the mechanics of palliative care are.
Great question. So what are the components of palliative care? In that first, let me go back. Okay, here are the components that are relevant. First, it has to be a interprofessional team that generally does a sophisticated assessment from a holistic perspective about someone's well-being. So it's about asking about symptoms, it's about asking about psychological and spiritual and physical distress. It's about understanding someone's concerns, worries, and fears. That's the assessment part. And then the care part is in a structured way, again, that's aligned with that person's goals, to try to, in a thoughtful and feasible way, address those concerns so that the care that person is receiving is aligned. It's a journey. So often the concerns someone has when they first, for example, receive palliative care are going to evolve, right? I mean, when someone first has a serious illness, one may be worried about that next round of chemotherapy or the side effects of the chemotherapy. And then when something new happens, new concerns evolve. And so what palliative care professionals attempt to do is to come alongside that person and both listen to those concerns and fears and then address them in as holistic a way as possible. Now, in the United States, palliative care is the most accessible, ironically, in the hospital. So in the United States, about 80% of hospitals that have 350 or more beds have a palliative care program. It's harder to access palliative care in the United States outside of the hospital, in clinics. In the Bay Area, we happen to be lucky. We have more access to palliative care here than most places, but in many places, there's less access outside of the hospital. But in clinics and in the home, those resources are variable across the United States in terms of receipt of care. And in fact, there's now increasingly a movement to provide video palliative care to people in rural areas for that very reason, because the access is variable outside of the hospital. Did that answer your question? Okay, great. Other questions? Yep.
You answered the question in terms of how to access this in the hospital. There isn't anything else. There are two questions I have. One, there's nothing available outside the hospital, question mark.
Okay.
And two, does your medical insurance pay for this?
Yes. Very good questions. So, yes, there are palliative care outpatient clinics and increasingly palliative care home-based programs that are starting around the country. Outpatient clinic, a regular palliative care specialty clinic increasingly is becoming available. We now, at UCSF, we have a palliative care clinic for cancer patients and then another palliative care for non-cancer patients. Sutter has a palliative care clinic. Kaiser has a palliative care clinic. So increasingly you can find palliative care clinics in our community. Now I have to tell you, in some other communities it's not so accessible. We're lucky here, we have more access to outpatient palliative care. And yes, insurance pays for palliative care just like they would pay for you going to a cardiologist. So it's specialty care, and you go to the cardiologist, you get care. The difference, and part of the reason palliative care has only now become increasingly supported, is that in a fee-for-service world, that is where the only person who gets paid is the doctor or the nurse practitioner, and nobody else on the team gets paid. If you have a kind of care that's predicated on an entire team being a part of the solution, then those folks don't get paid for except for some other kind of way. So many outpatient palliative care programs are subsidized through philanthropy or through health system support because we know it's the right thing to do and it actually does improve quality of life and well-being. And many large organizations, including the American Hospital Association, the American Society of Clinical Oncology, the American Heart Association, I could go on, have all basically stated that palliative care should be an integral part of care that people receive is for those specific conditions. And so with that kind of increasing pressure, there's an increasing growth of those services outside of the hospital. Yeah.
This is a question that might be a little bit off, but if you were, say, in a palliative care clinic or home-based setting, considering and you had a chronic illness, but you weren't necessarily dying, but some chronic pain issue or something, where part of the solution may be medications, there seems to be some restrictions now on outside of hospital access to stronger pain medications, or morphine or opiates. How is that sort of opiate crisis issue impacting on the kinds of services that somebody might need in palliative care?
It's a great question.
What are some alternatives to those opiates?
So it's a great question. It's definitely having an impact on people who have serious illness. And people who have serious illness and who have chronic pain these days, many of them are experiencing challenges with accessing medications that have benefited them in the past because of the opioid crisis, and particularly because opioids have led to many deaths and overdoses in the United States among people who don't have a serious illness. So most of the overdoses that we see occurring in the United States related to opioid overdoses are not occurring in people with serious illnesses. They're actually occurring in younger, middle-aged individuals who have a lot of other things going on in their life, that including a lot of mental health concerns, depression in particular, addiction, etc., that contribute to that crisis. That being said, that is affecting and influencing the access to those medications, even in the palliative care community. The good news, I would say, although it hadn't quite come to fruition yet, is I do think it's contributing to a lot more openness for a truly more holistic and integrated medicine approach towards care for people with serious illness. For example, in our practices, we work very closely with the Osher Center for Integrated Medicine. We try to make available to folks psychological services, acupuncture, chiropractic services, etc. And those resources used to be quite difficult to access through traditional medical care. So that's the good news. But there's actually a really important conversation going on right now about how many people who have serious illness and things like chronic pain are suffering tremendously because they're no longer able to access those medicines that enable them to have a meaningful quality of life. Yeah.
Are doctors actually prevented? I mean, if somebody has a real chronic illness, are doctors prevented from continuing to prescribe opiates? I mean, I'm just curious.
Yeah. So it's really a pretty remarkable time in our healthcare system with respect to the issue of opioids. We are not prevented, but the Drug Enforcement Agency is looking very carefully at anybody who's prescribing large doses of opioids. It is a quality measure, so I'm evaluated just like everyone else in our healthcare system by what proportion of our patients are receiving opioids. So there's a huge amount of scrutiny that doctors are facing now with respect to the use of opioids. So they are in a way being restricted through regulations and through oversight and those sort of things. Yeah. Yeah.
noticed that Kaiser and other places have palliative care, and mostly hospitals. Do you know if Sequoia is qualified to do it too?
Is Sequoia qualified to have its own palliative care clinic? Sure. I mean, I think if you had a clinic that provided an array of services with the right amount of resources, certainly one can think about integrating palliative care into those services. The biggest challenge with palliative care right now is access to palliative care specialists. So right now we only have about 125 palliative care trained specialists coming out of fellowship programs around the country. So just add that up, that's not a lot of people. And there's really only about one palliative care provider for every 64,000 people with serious illness or something like that. So that's why when I say we're lucky in the Bay Area because we actually have access to palliative care providers, they're still not hanging out on every corner. And so while it's certainly feasible, probably the best way for Sequoia to have access to palliative care services is to partner with a palliative care program that's already in existence and to try to figure out how to support a partnership that really provided, meaningful support to the residents here. Yeah.
I somehow missed the segue from palliative care to advanced planning.
Okay. So the segue is that in palliative care, oftentimes people will say, you shouldn't get it because it's too soon, or not yet, you don't need it yet. And what I would say is that yet is something none of us know. I could walk out of this onto Gary Boulevard right now, get hit by a bus, and very possible actually. And that not yet would suddenly be right there, right? So I think the segue is that when we think about serious illness and that whole idea is, I don't need that or that's not going to happen to me, the truth is, from the standpoint of having control of your life, if palliative care is going to sort of facilitate that, part of a big thing that palliative care does, and this is actually, I wanted to bring this up because this relates to your question earlier, is it tries to understand what people's goals and values are about their care and make sure that that's adequately articulated in a way that healthcare systems and providers can understand. And so that does include advanced care planning. And many times in palliative care, we'll ask people, okay, so what's important to you? Okay, you have a serious condition. What are those things that will be important to you when you're trying to make decisions about treatment A, B, or C? And doing A, B, C, D, or E thing. And that's where that advanced care planning comes right head to head with palliative care. Does that make sense?
So encouraging advanced planning is part of palliative care treatment.
It's part of palliative care treatment, and in my estimation, it should be happening way upstream from palliative care. So everybody knows in my family where my living will is, where my advanced directive is, because my feeling is I could become seriously ill tomorrow. So it is part of palliative care treatment because if you or your loved one is experiencing a serious illness, then that what if is no longer what if. You're actually on the journey of experiencing a serious illness that means decisions have to be made. But even if you're not experiencing serious illness right now, it's worth thinking about those what ifs, and that's where the advanced care planning piece comes in. Yeah.
Some of us about 6 months ago went to a presentation over at the Institute of Aging. It's called Marijuana for Seniors.
Yes.
And we learned a lot of interesting things, and there were some questions that were raised there. Clearly, marijuana is not legal in a federal sense. It can't be dispensed by medical doctors. But fitting into that scenario of alternative services like acupuncture and other kinds of things, how does the system in UCSF or Kaiser sort of address other alternative medicine approaches the patient may have and integrate that into palliative care setting.
So sometimes it's a bi-directional educational experience, right? There may be things where the person coming into the setting actually is more knowledgeable than the person who's providing the services. That being said, with respect to marijuana and THC and CBD, we're all doing our best to learn as much as possible, as fast as possible, because so many people are ingesting or inhaling or using as oils marijuana products. And so there's a huge amount of interest in learning that's going on. For the very reasons you said, it's not a federally approved substance, but it is in the state legal. Generally what providers in our community do is we try to provide as much education on what we do know and what we don't know about what a particular component of marijuana can do. And I will say that our knowledge about the benefits and burdens of marijuana in older adults is close to negligible. So happily, I just learned recently that the National Institutes of Health is beginning to actually fund studies of marijuana, not clinical trials because they can't do that, but they're basically using all of us as natural experiments. And what people are doing with respect to marijuana, they're trying to understand, and especially its impact on older adults, because we really do not know. We know actually in very young people, for example, that it has negative neurologic consequences. We don't really know, those neurologic consequences seem to be not as meaningful in people who are middle-aged, but we don't really know much about older adults. So I think there's a lot of learning to be had. But what we generally do is, from the standpoint of an alternative integrative medicine approach, we are all learning as much as we can to try to stay up to date on this as best we can. And then it's often a conversation about, these are the things that we have observed. This is what the literature tells us so far. This is what we can tell you. This is what we can't tell you. This is where you can go. These are the dispensaries that can give you different kinds of proportions of various agents.
It's a little bit after 3 o'clock, and I know you have a conference call.
Yes, I do.
Scheduled at 3, so we'll have to adjourn at this point, but thank you very much.
Thank you.